So let's talk about cases here. So 65-year-old male patient diagnosed with a stage 4 sigmoid cancer, synchronous metastasis, unresectable. He's in good performance status and has minor right upper quadrant discomfort, likely from his liver metastasis, but otherwise no really tumor-related symptoms, no signs of bowel obstruction, MMR expression, MMRP, so no MSI high or MMRD phenotype. No RAS or BRAF mutations are found. In first-line treatments, FOLFOX panitumumab, good to response. 4 months of treatment, he developed neurotoxicity, so 8 cycles of treatment, which is starting to affect his activities of daily living. So that's a standard left-sided RAS-RAF wild-type tumor treated with appropriate treatment, FOLFOX panitumumab. So what do you do now? So you're 8 cycles in, patient has response, is still responding, has some mild sensory neuropathy, but it has sensory neuropathy which is starting to affect activities of daily living, but it's working. So, and this is for the audience now, for you to choose on. Okay, so you continue FOLFOX panitumumab, you continue with 5-FU panitumumab maintenance, or 5-FU and panitumumab alone. You switch to K-Bev as maintenance therapy, switch to FOLFIRI plus panitumumab. You want to give complete break from therapy or something else. And if it's something else, you need to tell me what it is. Okay, so we see the answers in real time, which is great. Okay, so you can see whether you're right. There's no right or wrong actually here. I think there are preferences. Yeah. Okay, so Eric, what do you think?
Yeah, I tend to agree with what the majority said. That's what I would do also. I would take off the oxaliplatin a little bit like a stop and go or maintenance strategy that Emily de Gramont has developed. We do have less data, formally speaking, into that in the literature. These initial data were with FOLFOX or Capox plus bevacizumab. But in the setting, if we choose for FOLFOX panitumumab, which is a good choice, I think, in this patient, that's what I would do, yes.
Yeah. So, I mean, as you said, the data are not that solid for EGF receptor antibody maintenance.
There was something last year.
Sorry?
There was something last year, but I can't remember.
The Valentino study.
Italian study.
Yeah, the Valentino study, which actually compared 5-FU panitumumab to panitumumab single agent, and the addition of a fluoropyrimidine to panitumumab was actually helping patients have longer progression-free survival. Now, Pashtun, why not switch to K-Bev? Because we have a lot more data. Is it?
I was about to say, and also from a quality of life perspective, 5-FU maintenance with the panitumumab means every 2 weeks visit with a pump to go home with for another 46 hours, as opposed to one doctor visit with pills at home and a 15-minute to 30-minute bevacizumab push. I guess with the maintenance K-Bev, I think, is underutilized as a maintenance strategy. After 4 to 6 cycles of upfront, oxaliplatin-based chemotherapy, a switch to such a regimen, I think it's, from a quality of life standpoint, I think it's a good switch.
You could switch it to zolodipimab, and then it's a Q3 week schedule.
Yeah, but in the guidelines, in the European guidelines, we say don't combine
and the
anti-tumor antibodies with capecitabine. There are the data from the English study that says you should not do that.
But we've all done it.
Yeah,
it wouldn't make any sense.
Yeah. So Dr. Ilsen said, there's no real reason to switch to bevacizumab because, patient is stable on that. But I think, what we ignore, there's 2 points. I mean, great discussion. I mean, continued EGF receptor antibodies as maintenance therapy and not as, let's say, quality of life friendly, as bevacizumab, which is virtually non-toxic. All guidelines suggest you should not combine capecitabine with an EGF receptor antibody. That's based on European and NCCN guidelines.
But have you done it?
No.
Never?
I've never done it.
Really?
Sorry, I follow guidelines.
I'm
German,
I have done it in a few patients, and it's tolerated fine.
Okay, but there was also some negative interaction with activity, but there's a reason why the NCCN guidelines specifically say no to that.
There is a trial that is doing a maintenance CAPE with anti-EGFR. It would be interesting to see the results.
What we don't know is, the study that we talked about, 5FU plus panitumumab showed the combination is better than panitumumab. What we don't know is whether the fluoropyrimidine alone, capecitabine, could actually be. That's a German study which is ongoing. We don't have the results yet. But I think we have a consensus, so you drop the oxaliplatin and you continue with 5FU panitumumab based on data. Okay, so that's exactly what the patient did. Continued with 5FU panitumumab, stable disease after 2 months, but then really relatively fast progression of disease after 4 months, Of course, now, do you do a ctDNA test now to look for RAS and BRAF mutations? I mean, that's something which we talked about. Is this something you already integrate in your practice? And you can ask, what's a ctDNA assay? Then we'll educate you about these things, and we'll talk more about this actually quite a bit. So I think this is kind of the cutting edge emergent, field. So no, yes, kind of balancing in between those. Okay, not sure. I don't think we necessarily utilize this exactly unless, at this point in time, Eric pointed out there are trials ongoing right now looking at re-challenging with EGF receptor antibodies based on negative ctDNA for these mutations. But I strongly believe, the yeses will turn into the majority at some point in the next 5 years because that's what's going to happen. I don't think we need to talk about this more. We'll talk a little bit more about these next slide. So what do you choose as second-line treatment now? Let's say you didn't do a ctDNA test. Do you go to FOLF, and the FOLF theory is irinotecan plus BEV, so you don't have, you continue an EGF receptor antibody beyond progression. Use irinotecan, a single agent, and Rego, TAS102, or you would really look at the ctDNA analysis and see whether you continue EGF receptor antibody or switch to bevacizumab. Clear radiographic progression, shortly into maintenance therapy. Yeah. Okay. FOLFIRI Bev?
Yep.
Unanimous?
Yeah.
Do you use irinotecan Bev or FOLFIRI Bev?
Full
Kathy?
Oh, full fairy.
Me
Yeah.
too. Unless there's a lot of toxicity and, I want something milder. I
Okay.
think importantly, there was not even an option of reintroducing oxaliplatin, which I think is
Yeah.
an important
And
thing to point out, that
Right.
the progression was too rapid.
And
It's
you
too
didn't
rapid.
mention the PS, so we're presuming the PS is still good.
Yeah, yes. I mean, all these patients are athletes, they're great. Now, patients receives FOLFIRI Bev, that we all agreed on. And the third line treatment now, this patient is now some time out from FOLFOX. So can we use FOLFOX again? Should we use Rego, TAS102, or again, something else? And so Pashtun, what is your threshold to use FOLFOX compared to Rego or TAS?
I guess it depends on how the patient presented in terms of progression. If it was clear-cut progression, I would lean towards reintroducing oxaliplatin, which can work, depending on the study, at least a third, if not more. And then you could reserve or bridge the person to a trial at the time. So I think the reintroduction of oxaliplatin, since the patient never progressed, it was just given a break, is important to remember.
So, I mean, the right answer, of course, would always be clinical trial, because that's why I didn't put it on there, because that's always the right answer. And we should not underestimate that patients who are still in good performance status, will still be candidates for clinical trials. Very quick, a second case, 65-year-old male patient, now retroperitoneal metastases. Now it's actually symptomatic. And so clinical symptomatic, again, MMRP, no RAS and BRAF mutation. That's a cecal cancer now. So that's a right-sided tumor. So question is, what would you choose as first-line treatment? Right-sided tumor, RAS, RAF, wild type. And that's our last discussion that we have here.
Athlete.
He's an athlete, he's 65.
Yeah, he's an athlete,
Just an
65 year. I mean,
Astronaut.
the older I get, the younger my patients are, So, I mean, 65 looks very young, I mean, critically young,
Younger and younger each year.
Younger
right?
and younger each year. I mean, gosh, when you start looking at your retirement portfolio and think, anyway.
We missed, was he RAS and
RAS wild type.
and BRAF also?
Yeah, BRAF wild type, so it's all wild type, but right-sided tumor.
Yeah.
You see,
You need a receipt.
so triplet versus doublet in Bev. Kathy, would you do that in a marathon runner, a 65-year-old marathon runner?
Sure.
What's your cutoff? Who would not be a candidate for triplet?
Actually, 65 is kind of close, I have to be honest. Well, performance status.
You're looking at me.
Performance status obviously is the most important aspect.
Yeah.
Yeah.
Okay. Now, Eric, in Europe, especially when you're in Italy and you live in Pisa, I mean, there's really no limit, I see, for a triplet, right?
Yeah, the Italians, but maybe Italians are stronger than other Europeans. The Italians will get FOLFOXIRI in Pisa. In my center, we will treat not with FOLFOXIRI. We will give a doublet in view of the sequencing. And I'm not convinced that if you take everything into account, benefit, risk, in a patient like that, if I'm got it right with peritoneal metastasis,
Symptomatic
that,
disease.
symptomatic, that I think the doublet plus bevacizumab in our setting would be our preferred
Okay,
choice.
so you have two choices, you know.
Do you have an age limit at your center for triplet?
There is no age limit. There
preference?
is we use very few triplets in colorectal cancer in our
Yeah.
center. It's not age limit. It's, let's say, a discussion with the patient sometimes, but the majority, I will propose a doublet, not a
Okay,
triplet.
some more agreement toward triplet in a symptomatic right-sided cancer, you know, with a one-time chance to really get a response. Because I'm worried about, and this is for for the case was built up. I'm worried about, you know, this patient might not have a second-line treatment. Okay, thank you very much.